Okay, good morning, everyone. Thank you for joining us at it's a relatively early hour some places here in the U.S., but I'm interested to see where people are from. So if you want, put where you're logging in from in the chat. We can see what times they are. But we're gonna go ahead and get started so we can get. This is gonna be a really good hour here. So we're gonna talk today about IOP and scleral lenses. But first, just a little bit of history about kind of how we got to where we are today. So Jan, this is has always been your brainchild. So where did we start?
Yeah, about 5 years ago, I realized, and good morning, everybody. Thanks for joining us. About 5 years ago, then I realized that the prominence of the scleral lens as a superior device was not present anywhere. So we had to create our own meeting, and where we discuss things on an evidence basis. And the mission statement you see there on the right is to advance the discipline of scleral lens prescribing through the coordinated efforts of evidence-based research and clinical practice. And I want to take this opportunity to thank our two sponsors, Bausch and Lomb, Cooper Vision, Blanchard branch. We're very grateful for your support of this idealistic undertaking. And Bausch and Lomb is here represented by Patrick Marshall, and Cooper Vision is represented by Richard Dorer, Leah Johnson, and Marie-Christine Blanchard. Thank you for coming here.
Yeah, so thank you to everyone. And it looks like we've got people from all over the world. So Colombia, South Africa, Alabama, California, Chicago, hi Pam, New Mexico, Maine, Poland, Nebraska. So amazing. We're really excited to have everybody here. So on to the main show here. So today we've really deliberately for this meeting, which is research based, like to select people who are doing research and also people who may or may not be in the clinic. So we like to get a nice mix of people. So we think we've got a really good team here to share some of their research. And all of the speakers were selected based on their peer-reviewed contributions. And so we've got joining us first is going to be Jenny in the middle. Many of us know Jenny. And she's part of the SCOPE study group. They've looked at a lot of different outcomes of scleral lenses, but specifically they've published some this year on the different measurements used. And I think we'll be talking a lot today about what different measurements are used to measure IOP. And whether or not they're valid. And then we'll also have Gloria Chiu, who's basically our clinical, Gloria does it all. She's in clinic full time and also manages to do some research and looked at this at intraocular pressure and a batch of real patients coming through her clinic, which is going to be really interesting to hear about. And then we have a special guest who maybe a lot of us aren't as familiar with, Dr. Dan Samaha, and he works with at University of Montreal with Langis Michaud, who most of us are probably familiar with, but Dan is in the back of the eye, and he does some glaucoma research. So he teamed up with Langis, and he'll talk to us about some of the optic nerve parameters that are being looked at for IOP. So a really exciting morning this will be. And the way this works, and this is, again, Jan really wanted this meeting to be something where we can come together and discuss these papers, because so often it's just somebody up there lecturing to you, and then you kind of maybe get some questions in here and there. But we really want the audience to be participating. And so put questions into the Q&A. If we can manage it, we'll try to unmute you so that some of you can actually speak to us and maybe share some of your experiences. But we're going to hear from these three experts first, and then we're going to invite we have a couple extra guests, Dr. Jason Nichols and Langis Michaud, who are big heavy hitters in the research world. And so we're going to get their perspective and this perspective of you as audience members. So with that, I think, Jenny, you are going to go first. So I am going to end my screen share and let you take over here. And while Jenny's doing that, I'll just encourage you guys to either start thinking of questions that you want to ask, or you can go ahead and put them in the Q&A whenever you're ready. But with that, Jenny, I will pass it over to you, and thanks for joining us.
Wonderful. Thank you so much for letting me be a part of this. This is quite an honor, and I'm so excited. I am at The Ohio State University, and I am a clinician and a researcher. So I love it when things all kind of come together like this, and we get an opportunity to talk about what we do and what we know and where things are going in our field. So first, just by way of introduction, I think probably everybody here knows that IOP is interesting with scleral lens wear, but this isn't really a new area at all. In the 1950s, back when scleral lenses were PMMA lenses, people were thinking about it then. Hugert in the 1950s brought up the possibility that IOP could be affected by scleral lens wear. And in the 60s, Miller and Carroll talked about what they called cling of a scleral lens. So the fact that the lens would actually have force required to remove the lens might mean that there's induced pressure on the eye. So we fast forward to the time when gas permeable lenses are available and sclerals can be made with them, and the world is wonderful. And a study by McMonnies and Bonham in 2007 was done to find out if pressure, so just digital force on the eye, so just taking a finger, if you push that on the eye, does that increase the IOP? And they found that it did. And so then really people started to think more about what the effects of with a scleral lens on the surface of the eye. But here's the problem. You can't measure IOP when you have a scleral lens on a cornea. You have a giant dome that's kind of, a force field, protects you from standard means of measuring pressure. And so you have to use different instrumentation. And we are very used to Goldman, we have Tonopens, we have things, but they all require using the cornea. So it's taken some creativity, I think, and some really great studies have happened using alternate instrumentation. So the first study, a really great study that was done by Sherry Now, Muriel Shornack at Mayo with some glaucoma specialists as well, was done with 29 healthy subjects and just one diameter of lens, and found they used peripheral pneumatonometry, and they found no change in IOP. But I'm not sure if every clinician out there knows about pneumatonometry. Pneumatonometry is used frequently in glaucoma specialty practices, so a lot of ophthalmologists have a pneumatonometer around, but it's actually designed to be used on the cornea, and studies have been done. I'm going to show you a slide with some pictures in a little bit here, but studies have been done that have shown that using a pneumatonometer in the periphery, so on the sclera as opposed to the cornea, it has a direct relationship so that you can actually calculate back and forth what that change would be. Later in 2019, Michaud and his group found an increase in IOP when they were using a transpalpebral tonometer. And a transpalpebral tonometer, there's only one right now, so the brand name is the Diaton. The Diaton is kind of known for its portability, and it is a screening tool, but it is used, and I'll show you a picture here shortly, it is used over the eyelid so that the measurement is done on the upper sclera. And you can measure IOP with both of those. So it's interesting that we had these two really well done studies, but they had different results. And we were really curious, what does it all mean? What can we draw from this? So this is the scope group. I'm sure a lot of these faces are familiar, but I have to show them because all the research that we did was done as a team. And without Jen Harthen and Amy Now, Sherry Now, Muriel Shornack, Ellen Shorter, this research wouldn't have been done. So we really enjoyed putting this project together, and we really enjoy working with each other. So I feel very fortunate. what we did was we put together a study with 20 healthy subjects. We wanted to know if lens diameter had any factor. So we had two different lens diameters, a 15.2 and an 18.0. And we had randomization of the subjects so that half of them used one diameter first and half of them used the other size diameter first. And they were just worn in succession. So each subject wore a lens on the right eye during the study, and the left eye was also measured to be used as a control. We used peripheral pneumotonometry and transpalpebral tonometry, both at all of the time points in both eyes. And additionally, we wanted to know if head position played any factor, because with a diaton, you actually have to tilt your head back and look down. And we wanted to make sure that that posture was not having anything to do with it. So we did pneumotonometry in both a head erect posture and in the head tilt posture that matched what is required for the diaton. So we measured the IOP in both eyes and compared the two eyes statistically. And then we also looked at the change in IOP, because the change was probably more telling than anything else. The two instruments had very different numerical values. And so looking at just the change with one was really different than from the other. These are just some fun pics in here. I have to have a disclaimer that we did not have proper head tilt, but these were not during the study. This was before the study began, so we could just have some fun here. This is a picture in case you haven't seen the diaton. You can see here how the instrument comes down on the upper eyelid, and it actually kind of kicks in there to actually get the measurement. It's quite delightful. Over on in the right inset, you can see the pictures of the pneumotonometry, and on the left, you'll see it performed on the cornea, and then to the right is actually on the sclera. So we did paired t-tests first of the control eye and the eye that was wearing the scleral lenses, just so we could make sure that we were taking any kind of diurnal effect into consideration. And interestingly, when we just did paired t-tests, we found that there was no significant change when we were using, I might have this written on here wrong, when we were using pneumotonometry. But we did have a significant difference when we were using transpalpebral tonometry. So we did an analysis of variance of the change in IOP. So the change would be then in the study eye from baseline to each of the study points. And the study points were just after the lens was inserted, and then after an hour of wear, and then again after the lens was removed. When we did analysis of variance, oops, let me go back to this one for a second here. When we did analysis of variance, we looked at the factors of the lens size, as well as we actually looked at the order that the lenses were done. We looked at all kinds of different things, but the only factor that we could find that was significantly different in this whole study was what instrument was used to take the measurements. So this is a slide with lots of data on it. This has all of the changes in IOP that we measured throughout the study. And it's divided, as you can see, by the two different diameters of lenses. We didn't find any difference between the two diameters at all. You can also see that for each one of those, we have a study eye and a control eye change. And what is interesting is in the transpalpebral tonometry column. It only happened in the eyes that were wearing lenses, but you could see that the changes were enormous. 65% change in IOP with the diaton just after inserting the scleral lens. After an hour, there's a 65% change from baseline. And those were in the smaller diameter. It was slightly bigger in the larger diameter lenses, but you're seeing really large differences. Whereas with the peripheral pneumotonometry, the very small differences, differences of around, I think 1.7 was the biggest change that we found. And that kind of is acceptable within Goldman standards as well. So we really wanted to think about this. Why in the world are we showing this? This isn't answering our question. Does IOP go up or not? That was our whole aim. But really what we found was not what we expected. We found that instrumentation was just very, very different. And so looking back through different studies of the two instruments, it really kind of clarified, again, that pneumatonometry is a well-regarded, highly regarded and used in glaucoma practice. And so perhaps it is more reliable than using a diaton, which studies have shown is only reliable in healthy subjects who have normal IOP. You cannot use it for anything diagnostic, according to studies that have been done on the tool. But it's great if you're going to go out and do a vision screening and you want to have something portable. So our findings, coupled with the different kinds of studies that have been done, and the thought that perhaps the fact that a scleral lens is compressing the tissue, the ocular tissue, maybe that has an effect on the measurements, because it was only measurements that a scleral lens was on the eye that showed differences when you were using the diaton. So I don't know, we may have brought up more questions than answers, but I think the most important thing here is that we can't jump to conclusions based on just one instrument, whether or not there's a change in IOP.
Great. Thank you so much, Jenny. So you can go ahead and stop sharing, and then Gloria, you can share your slides. Now, while you're doing that, and actually, Jenny, if you want to keep your camera and volume on, I know there's been a couple of questions in the chat. So with that, we'd ask you, you know, and Hal has brought up a couple of things in the chat and says he hasn't taken statistics in a while, but it seems like that diaton has a high standard deviation. I know I've also found that in my research, right? There's lots of publications on the use of the diaton. And of course, Jenny, you're right. That's, you know, found in normalized. Sometimes it's reliable, kind of, sometimes it's not. So I guess my question for it is, are we using it wrong? Is there something that, right? So why are some studies finding it's usable? And that's sort of what I've thought, right? Or is it work on some eyelids that have certain types of tones? You know, what are your thoughts on whether or not we can use this instrument?
Well, I think all of that is important. I don't think we completely know, but what we did, Jen Harthen was very, had a really good time with as well, because she was using the diaton and she was purposefully putting it in the wrong places sometimes, not for our study data, but just kind of experimenting. What if you hit the end of the edge of the lens? You know, what if you're closer to the lens as opposed to farther away? And it did seem she got some really crazy numbers if you did accidentally hit that scleral lens too. So I think that's certainly something that if you're going to use it regularly, you need to practice it. We had the same person doing it every time so that we had perfect consistency. But we also did, as a part of our study, and I didn't even talk about some of the other things, we did some repeatability things with the instruments too, just to see what was going on there. And really the diaton was not as repeatable as pneumatonometry was in the study. So I think that I would be hesitant to base any huge conclusions on the diaton right now, just based on all the things that are being said about it right now and all the findings that are coming from these studies.
Yeah, and great. And we can table that for now, because I think that that's another bigger discussion topic too. But so Gloria, you can go ahead and share your screen, and then if you so Gloria is going to share with us yet another type of technique, I believe, used to measure IOP.
Maria, can you see my screen?
No.
Okay, I thought I shared it, so let me do that again. Is it shared?
I don't think so.
I don't know why. Let's see here. I'm pressing the... Okay, how about now?
There we go.
Okay, let me put it into presentation mode, and how's that?
Perfect.
Okay, all right. So good morning, everyone. My name is Gloria Chiu, and I practice at the USC Roski Eye Institute in Los Angeles, California. And I've been there for almost 12 years. So it's been really fun working with within the Department of Ophthalmology with some wonderful corneal specialists, as well as kind of experts in parts all around the eye. And I'm very excited to be here today with all of you. I think that it's a very exciting time for us in the field of scleral lenses today. more and more practitioners are fitting scleral lenses. We're sharing our results with each other at meetings such as this and GSLS. And we're also learning from each other and learning how to fit lenses better. In addition, we're detecting complications and challenges and knowing how to better manage these eyes. And now we're actually looking forward to potential long-term implications of wearing these large diameter lenses that rest over the drainage area of the eye. So that brings us to the topic of scleral lenses and intraocular pressure. And thank you, Jenny, for reviewing your study. Excellent presentation. And so today we're going to be talking a little bit first about kind of the history of where we came here. So collectively, we have inquisitive minds. It's 8 o'clock here in Los Angeles in California. I'm not a morning person. My whole family is asleep. But I am thrilled to be here today because I am curious about research, and I'm just so fascinated about these studies that we're doing at all our different clinics around the world. So with our inquisitive minds collectively, we have more research and more publications. It's hard to believe that only 5 years ago, a study published by McManus titled A Hypothesis That Scleral Contact Lenses Could Elevate Intraocular Pressure came out. And shortly after that study, we've seen more and more research papers discussing this relationship. And it was very neat that the September edition in Optometry and Vision Science was dedicated entirely to scleral lenses. So it's just a testament to kind of how far we've come in terms of studying these lenses and their effects on the eyes, both benefits and complications. So I will be talking about one particular study that I had the pleasure of working with two other people, Kevin Shinazi and Veronica Izazaki. The title of our paper is Effect of Scleral Lens Wear on Central Corneal Thickness and Intraocular Pressure in Patients with Ocular Surface Disease. So as with any study, you have to look at the design and the pros and cons of every study. Now, first of all, although this paper was officially published in November of 2020, it had been accepted a whole year prior, and the data collection had been done years prior. So kind of took a while for the paper to come out. As we know, research can be slow, especially in academic settings. So this was a retrospective study, and we excluded eyes with irregular corneas. So we did not specifically look at this relationship of scleral lens wear and IOP in ectatic corneas, keratoconus, or post-surgical corneas. And we did not utilize the anterior segment OCT when we were looking at the central corneal thickness component. The pros of this study was that we used real patients. And several of the studies that I had reviewed prior to conducting this one had used young, healthy patients with kind of a smaller age range, and most of them did not have any ocular pathology. So these were real patients that I was seeing in clinic that required scleral lens wear for their ocular surface disease. These were also custom designed and ordered scleral lenses. So they weren't trial lenses that I was using the same lens in each patient. They were their own lenses, fit ideally to contour their eye shape. These were real life wearing conditions. And again, we had a wider age range. So there were 25 subjects, 46 eyes with ocular surface disease. And in the table on the right, you can see that the subjects predominantly had general dry eye or dry eye from GVHD. There was one Sjogren's and one SJS patient. The average age was 57. So again, almost 30 years higher than the average age in some of the previously published studies, but the age range did vary from 26 to 83. I used two diameter lenses, 17 and 18. And again, because this is a real world setting, I wanted to look at all the parameters. So the average DK of the lenses was about 107 and 109. in the right and left eye, and the average center thickness was about 0.33 millimeters, both for the right and left eyes. This data was collected over a period of about a year from May 2016 to July 2017. And we used, unlike some of the studies that Jenny just discussed, I used a tonopen because this is what I use typically in clinic. We also measured central corneal thickness by an ultrasound pachymeter. And these were our study results. So the average wearing time of my patients was about 11.5 hours, plus or minus 2.6 hours per day. The wearing time today means the self-reported number of hours that these patients had been wearing their lenses that day when they were coming to see me. So in practice, I always ask several questions. What solutions do you use? Do you sleep in your lenses? How many hours have you had your lens on today? And in general, how many hours do you wear your lenses on a daily basis? So again, slightly different from some of the previous studies that looked at a very concrete length of time, whether it was 2 hours wearing the lens, 4 hours, or 8 hours. So this variable fluctuated with my patients, and these were self-reported times. However, most of them had been wearing them for 4.5 hours, which is again comparable to some of the more designed studies. So what did we find in this study? Well, we did not find a significant relationship between scleral lens wear and IOP. We found a mean decrease of 0.89 millimeters of mercury. And this was with both eyes combined. So we also did break down the data and look at results from just the right eye and just the left eye. And even in those sets of data, there was no significant relationship. So we looked at it combined. Although our topic today is IOP, we also did look at central corneal thickness in these patients and found a significant increase of about 1% in central corneal thickness. So in measuring the center thickness, I manually used a ultrasound machine. And you could say that, it may not be entirely repeatable because I'm trying to estimate the center of the cornea. So it would be more accurate if I were using an anterior segment OCT to measure those changes before and after wear. So something to consider for future studies and the study design. And I know that one of the later sessions for the International Forum of Scleral Lens Research, I think in 2 more weeks, they're going to be talking about oxygen and hypoxia. So maybe this topic will come up. So we did find an average difference between pre and post central corneal thickness of about 7 microns. And we attributed that to subclinical hypoxic conditions created by the scleral lens wear. And studies support that you need about 4 to 6% increase before you see clinical changes, whether in haze in the cornea or where it starts to affect their vision. So this amount of 1% was not clinically significant to the patient. So that is what we found in this particular study, but I did want to briefly just touch upon this poster, which is in the GSLS poster session currently. So my colleague Kent Wynn and I at USC looked at the effect of scleral lens wear on optic disc perfusion, and we used the optical coherence tomography angiography, so OCTA. And I think, we are looking at implications of scleral lens wear on optic nerve head morphology, and you'll be hearing in the next study about how it affects the structures inside of the eye. This is looking at blood vessel perfusion, and this was a pilot study, so we only had 1 subject, but in that 1 subject wearing 2 diameters of scleral lenses with an 18.5 and a 16 millimeter over an 8-hour period, we did not find any changes, but we really need to design a prospective study to look at this in more detail. And we will be discussing and having some more lively conversation. And some things to think about is scleral lens and IOP in relation to, diameter. Does it matter? If it's larger, are we spreading out the area of compression over the drainage system? The fit of the lens, does a tight fit versus an ideal fit matter? Patient age, because we know that the conjunctival tissue changes over time. The method of IOP measurement, trends seen in practice, and are we as doctors seeing glaucoma develop in our patients? So I think it'd be interesting to see more studies about that. So with that, Maria, I will turn it back to you. And I am going to stop sharing my screen.
Great, great. And Gloria, if you'll keep your audio and video on for just a moment, because I do want to ask you just one question, which you sort of touched on. And Dan, if you want to start sharing your screen whenever you're ready, that's fine. And this has come up with a couple questions, and you already kind of touched on it, but just what, in terms of what your thoughts are, people asked about, does the mass of the lens, does the diameter of the lens, does the sag of the lens, people even asking about if you use OCT to actually look if the lens is overlying the trabecular meshwork. I mean, do you think that there's a big, like there's one fit of a scleral lens, like a profilometry lens, that's not going to cause it? Or is it maybe more of a patient specific phenomenon?
So wonderful questions. And I certainly don't have answers to all of those that you just rattled off. I think we need to be sitting with a cup of coffee or a glass of wine to discuss all of those things in detail. But, you know, I don't know. So in this study, we looked at two diameters. So we had lenses with 17 and 18 millimeters diameter. And, you know, they wore them for longer periods of time. And I tried to fit them as ideal as possible. So I did look for impingement. I did, you know, made sure there was an edge lift, and ordered these custom lenses that the patients wore prior to checking their IOP after sometimes weeks and months of wear. So this study was unique in that it looked at changes in real life over longer periods of time than just, okay, this, you know, this student that we recruited is going to wear the lens for 6 hours. We're going to measure it on this day. These were real patients in a real life setting. You know, I don't know the answer, and I don't know if using profilometry and designing more aligned lenses will not affect the IOP, but there is still compression and pressure. There's something on the eye. So I think there's something to be said about that. And I think just as we continue to share our experiences through research and forums like this, we'll be learning more.
Yeah, great, great. Love that. And I agree with everything you say, but we'll maybe discuss that a little bit later, because we've got, I know Langis is probably dying to say something too. So, we've got some other people on the panel to share more with us too. So Dan Samaha, again, just a reminder to you who don't know Dan, he is working on faculty up at University of Montreal. He maybe will give us a quick background of where he comes from, but he works with Langis and did the study that they just recently published looking at some optic nerve head parameters. So I will toss it over to you, Dan, and looking forward to hear what you have to say.
Thank you, Maria. I'd just like to thank the organizing committee for allowing me to step out of my comfort zone and discuss scleral lenses to all these experts today. So hopefully I'll be able to follow up from the previous speakers, which, wow, you guys do great research, and I'm looking forward to seeing what the future holds for IOP studies with scleral lenses. So I guess I'm the only one. I just want to mention there was no conflict of interest for this presentation, but I'd like to extend a special thanks to Langis and Richard Ward for the guidance they gave me on fitting procedures for scleral lenses, seeing I don't do much fitting in my regular practice. Like Maria said, I work more at the back of the eye. So this was a real eye-opener for me and a real interesting project, and the results were really mind-boggling. So I thank you for allowing me to share these results today. So as the previous speakers mentioned, the research is still scarce as pertaining to IOP changes with scleral lenses because of the method limitations. We've used diatom at the Montreal University School of Optometry and found, just as Dr. Fogt, that there was high variability inter and intra individual measurements. As well, we don't have pneumotonometry, but research has been shown that both methods are not interchangeable. So that also includes the that also causes researchers to step back and wonder, well, which method should we be using for IOP measurement during scleral lenses? Recently, a study used fenestrated lenses and showed an acute increase in IOP immediately after insertion of the scleral lens. However, we couldn't account for fluid mechanics under the lens, but already showing this increase in pressure tells us that there might be some kind of compression from the landing zone. Add to that the fluid mechanics under the lens, and that might even contribute even more to increasing the pressure. So undeniably, we have to look elsewhere in order to assess the effect of scleral lenses on IOP. Notably, OCT imaging in the past few years has been shown to be extremely repeatable, very reliable, and very precise in order to measure even minute changes in IOP at the optic nerve head. Notably, I'll be discussing today Bruch's membrane opening minimum rim width, or MRW for short, and it's been shown to be very reliable. So basically, it detects the opening from the Bruch's membrane, as you can see here, at the optic nerve head. And the software automatically measures the shortest distance from that opening to the internal limiting membrane. And that is what this parameter is measuring. So the distance, the thickness of that neuroretinal rim. And so it has been shown to be very specific because the way it measures the tissue, it considers the orientation of the optic nerve head in relation to the fovea. So it's extremely precise in order to measure inter and intra individual variations, physiological variations in the population. And it's shown to be very repeatable, very specific, and very sensitive measurements. So we sought to assess the effect of IOP, the effect of scleral lenses on the optic nerve head, and trying to interpret that to see if it could be translated into a change in IOP in the eye. So in our study, 20 participants were fitted with a 16 millimeter Zen lens, so only one diameter was used, because we had previously done a study the year before that demonstrated no significant change in all of the parameters, whether we use a smaller lens or a larger lens. Clearance and landing zones were verified with OCT imaging, so we did not accept any clearance of less than 200 or over 300 microns. Obviously, no compression was tolerated in order to completely control any compression at the episcleral level or above the trabecular meshwork. Interestingly, we know that the MRW measurements tend to have a diurnal variation, kind of similar to IOP, a diurnal curve throughout the day. This variation is specific to the individual, so it cannot be translated to all the population. So we took the participants before fitting the lenses on them, and we went through a series of measurements throughout the day before the lens were put in to assess the MRW diurnal variations for each individual. So that way, when we put the lens in the next day and carry out the same measurements at the same hours, we'd be able to subtract those diurnal variations from our measurements and assess the true variation in MRW exerted specifically by the scleral lens. So we measured it at time 0, 2 hours later, and then 6 hours later in each individual in only one eye. So here are the results. We weren't sure how the scleral lens would actually affect data acquisition through an OCT. So we repeated the measurements immediately before lens insertion and 20 minutes afterwards to make sure the lens was properly positioned on the surface of the eye. And we found absolutely no change in the measurements with or without the lens at time 0. So we now know that putting a scleral lens on the surface will not affect data acquisition for optic nerve head parameters. So already at 2 hours, we see a significant decrease in the minimal rim width, and a further decrease after 4 hours after that. So after 6 hours, we notice a significant decrease in retinal nerve fiber layer thickness. When we compare to our diurnal variation curve, so without lenses and with lenses, we notice that there's a significant difference between both measurements, a difference of of about 3.35 microns. So how does this translate? How can we interpret that measurement in terms of IOP change? So looking at a recent study from Dr. Patel, who measured the MRW in primates after greatly increasing IOP with pneumotonometry, he found a linear decrease in minimum rim width as the pressure was increased. Now, knowing that primate eyes and human eyes have very similar optic nerve head parameters and optic nerve head biomechanics, we can start comparing these changes in MRW in primates with the changes seen in humans. So basically, we found that there was a trend in our BMO MRW that clearly demonstrates a steady decrease from baseline values while the scleral lens is in place. Now, the obvious question is, how can this variation be quantified? Well, using this graph, a change of 3.35 microns signifies a change in IOP of between 5 and 10 millimeters of mercury. Now, we can't assess for sure that the IOP was increased because we didn't measure IOP. Well, we tried measuring with diaton and found extremely variable data as the previous speakers. But we do know that the changes seen at the optic nerve head with our research were identical to changes seen when we increase IOP in primate eyes. So we can start advancing the hypothesis that, well, scleral lens might affect the IOP in a negative way, or increase IOP in the eye after 2 and 6 hours of lens wear. So this was a real eye-opener. We're looking to do a further study on that, recruiting more patients and recruiting real-time patients who are regularly fitted with scleral lenses and repeating these measurements over several weeks to see if there's a trend, and not just a trend seen on that one day, but on several weeks. So I'm looking forward to these results, and thank you for allowing me to share these results with you. It was really interesting having this discussion this morning.
Awesome. Thank you so much, Dan. It's so fun to have you here. So you can actually keep your video on and you can mute yourself if you want. And I'll go ahead and invite all the other speakers, Gloria and Jenny, and then Jason and Langis, if you guys want to turn your cameras on, and we'll kind of start more of a discussion. So a lot of questions in the chat, so I'll kind of go through them. But first, I just want to give Langis and Jason both, is there anything that you guys wanted to add from what's already been discussed before we start answering some questions?
I think that, you know, these research are crucial in the field because we still not fully understand what are the effects of a scleral lens on the eye. And certainly it raised some, you know, not red flags, but yellow flags at least. Just like hypoxia, you know, I don't believe that we will generate glaucoma with an increase of 5 millimeter of mercury IOP pressure, but on susceptible patients, meaning that patients already on their glaucoma medication, the last thing that we want to have is a high fluctuation of the IOP during the day, right? So we want to stabilize that IOP. So it may be a risk factor. So lens wear may be a risk factor for a glaucoma patient. We don't know still yet, and we have to design longitudinal study to establish that as a fact. But you know, it's certainly a warning sign. The second thing is that, you know, in one study, it duplicates exactly the results we had before, meaning that the diameter of the lens doesn't matter. And it's a belief in the field that the larger the lens is, it will be more supported by the conjunctiva. It's all wrong. It's depending on the design, you know, and it's all dependent on where the lens is landing. And if you exert the pressure of this lens on a specific point of the conjunctiva, it doesn't matter how many plastic remains over the surface. You know, some lenses, just like the pros lenses, are designed differently, and are in fact larger lenses in their case are more supported by the conjunctiva because they are designed by tangent and not by curves. So and they also allow for tear exchange. So it's all depend on the design, and you have to know your design before concluding that this lens will be more affecting IOP than the other one. So a lot of unanswered questions still, but we have at least some indications where to direct our research in the following years.
Great, thank you, Langis.
I'd just like to add that since we're using scleral lenses more and more in the general population, we're going to see these patients wearing scleral lenses as they get older and older, where those types of characteristics become more and more troublesome. For example, a patient who's still wearing scleral lenses after the age of 50, 60, because he's always been used to it and because the optics are just amazing, well, that might be a little more important to assess afterwards. I'm not really worried about the young patient, the young keratoconus patients, 20, 30 years old, but as they get older, they'll keep wearing these lenses because we're just using them more and more in the community.
Sure, Jason, did you have something to add?
Yeah, first I just want to thank Jan and the IFSLR for partnering with the GSLS. It's just a great opportunity for all of us to come together as we celebrate specialty lenses and in particular scleral lenses. The point I wanted to make is that I think it's really important that we kind of think about any changes that might be happening as it relates to sort of structure and function. And the last presentation touches exactly on that. So in other words, are any changes that are occurring because of scleral lens wear really having an impact on a physiological system that has normally built-in redundancies that can handle stresses? And I think structure function studies like the last one are really important in unraveling what may be happening here or may not.
Yeah, you bring up a really good point, and I know Jan wants to say something here, so we'll go ahead and let you speak.
Yeah, no, I think it's a very important point that Jason bring up here, that we need to consider the structure and function. And what puzzled me is that the scleral lens lands somewhere on the conjunctiva and potentially could impede the outflow through conjunctival vessels. But you got to keep in mind that aqueous has a number of other routes that it uses in normal physiological circumstances. For instance, the aqueous can find its way from canal of Schlemm into the scleral venous plexus, and also in addition, the uveal ciliary body venous plexus. We must not forget that we have something called the uveoscleral outflow, which doesn't follow vessels. It's just like a leakage through the eye. And so if the scleral lens is just pressing one point, wouldn't the other outflow routes pick up the slack? And then one more point, we use instruments to measure intraocular pressure that are calibrated on the cornea. Now, if you look at the structure, again, I'm the anatomist here. If you look at the scleral structure, it uses the same components, but it's a totally different composition of these components. And if you handled an eyeball, you can tell the difference in rigidity between the sclera and the cornea. So the validity of using instruments calibrated with cornea at best is comparative. I think that is maybe the answer to the first lecture there that found that, I think that was Fogt study, Jenny Fogt study, that found that the significant result was that these tonometers measure different things, and therefore you get different values. Anyway, bottom line is don't forget the anatomy and physiology.
Great. I want to bring up another, and I want Jenny and Gloria's opinion on this as clinicians who see patients. So based on everything that we know, do you measure IOP in your scleral lens patients, and how do we do it in a meaningful way?
Jenny, you want to go?
Yeah, thanks, Gloria. Yeah, absolutely. We need to measure IOP in scleral lens wearers. I think that's critical, and whether they have glaucoma or not, you know, we need to be measuring that. And so, yes, absolutely, I do. Kind of as a going forward with that, and also with a question that was in the chat as well. IOP can be affected simply by removing a lens as well. And so you need to think about that too when you're measuring IOP in clinic. There was a study way back in 1991 by Kahn and Graham where they measured pressure after removing soft contact lenses. And they found that the pressure did not return to baseline until 5 minutes after a soft lens had been removed. And so I think when we look too hard at IOP, we're looking at a number. IOP is not the disease. You know, IOP is a measurement. And so we always have to keep in mind that we need to be consistent about when we're taking measurements if we're really going to compare them from visit to visit. And we need to think about the fact that a mechanical change can actually give a different measurement, and that measurement does not mean that there's a disease there. We don't know yet, and that's why it's great with Dan's work as well, that we're looking at structural things to find out if these increases in pressure really cause a problem. And that's the bottom line. Is there a problem, or is this just, are we just chasing things around, looking at different ways to measure something that maybe is just not as big of a deal as what we're making it out to be?
I don't believe that at removal, you have the true measurement of the pressure, because you just release the outflow and you just release the compression of the episcleral veins. So there's no real clinical value, I think, based on the fact that we evaluate IOP for IOP, not for IOP related to scleral lens wear. So the long-term physiological changes, looking at the nerve, scanning the nerve, the visual field are still, I think, the key factors to evaluate what will be the outcome.
Yeah, Gloria, I'll give you a chance in a sec. Just to add to what you say, Langis, I agree. And we also did a similar study here at UH that looked and found similar findings. We didn't find quite a statistical difference, but definitely more thinning in the that optic nerve minimum rim width in the scleral lens wearing eyes. But to throw another wrench into that, we also were looking at eye care immediately after lens removal. So within 20 seconds, we would measure it, and we found some increases there, but they did not match up to the changes that were greater at the optic nerve head parameter. So I'm definitely in that boat of we need to look more long-term at optic nerve head parameters, because we just don't know what those instruments of the IOP are really telling us. All right, Gloria, go ahead.
Okay, so, you know, it's interesting because when I started fitting scleral lenses, you know, during my residency in 2008 or 2009, I did not routinely measure IOP in every single contact lens or scleral lens follow-up, because that wasn't my main goal to follow IOP. It was to make sure I was getting a good fit of the lens. So for many years, I maybe measured it like once a year when I was doing more comprehensive tests, but not during a scleral lens follow-up or you know, they're coming back. I would just take it off stain, look at compression on the conjunctiva to make sure I was getting an ideal fit. I really didn't think about the IOP issue until years later. So honestly, it wasn't until maybe about 2015, maybe 5 or 6 years ago, when this topic started to be discussed, that I thought, oh my gosh, I should be measuring IOP. So that's when I started measuring it more routinely, not just on their consultations and annuals, but in between after lens wear. And for my particular study, I should mention, because it was a retrospective study, again, IOP wasn't my primary goal in seeing these patients. It was designing good fitting lenses and monitoring their ocular health as a whole. So in measuring IOP with the tonopen for my study, I would take the lens off. I would then stain with fluorescein and look at the conjunctiva first. Then I would measure IOP. So it wasn't 5 seconds after removal. My data was collected, I would probably say a few minutes after. And again, that was the retrospective design of the study. If people are designing studies, they might say, you know, IOP is my primary goal in this study. I'm going to measure it exactly this length of time after removal. So that's something to keep in mind, that I started measuring IOP more because then I was worried, you know, with patients not getting, if they weren't seeing another doctor, am I missing glaucoma? I was never thinking, is my scleral lens wear causing glaucoma? I was thinking, oh, what if they have glaucoma and I'm missing it? That's when I started looking at the nerve more during visits and measuring IOP. And I would catch a few in their mid-20s, and I was like, ooh, you need to go back to see your ophthalmologist or your glaucoma doctor. Something's not right. But I never thought it was, I don't think it was ever related to the scleral lens fit. But I think that's what we'll have to look at, you know, now that we're collecting data over many years to see, you know, changes, you know, structure and function. Are we seeing changes in the optic nerve itself, in fields, and, you know, looking at morphology, perfusion, all of these exciting things.
Great. You know, just to summarize, if you each in just a couple of words. So when you say you measure IOP, what instrument do you use and how quickly do you measure it after you remove the lens? Or is it different?
Oh, is that for me?
For you or Jenny or Langis, anyone who sees a patient with scleral lenses.
Habitually, depending on the cornea, regular cornea, I will use Goldman. Irregular cornea, I'm more and more with the ORA or the Corvus because I think it's more reliable. Applanation on a distorted cornea is not that reliable. So biomechanical aspects have to be taken in account, and certainly we have a better understanding of what's going on there. And the overall biomechanical components of the sclera is an unknown world as well. And we know that it may influence the fact that, you know, more rigid sclera, for example, will just, you know, transfer the pressure over the optic nerve, where there is a short-term probably compensation, but the long-term, it cannot sustain that. So, and I'm really cautious about keratoconus patients on fitting scleral lenses, because we know that keratoconus patients can be affected by low tension glaucoma or normotensive glaucoma, especially if they are obese, suffering from sleep apnea. These are all factors, you know, that can just trigger glaucoma. So in those patients, I'm really cautious to follow the optic nerve with OCT scans, all that stuff.
Yeah, go ahead.
Yeah, I just want to point out that the scleral lens and IOP issue is not a new phenomenon. In fact, the contact lens historian, Dick Pearson from London, he said that this issue is as old as the lenses.
Yeah.
Mm-hmm.
Okay, so we've just got a couple more minutes here. So thank you guys. And I know I think some of these questions we touched on. One last question, and this is you can put it in the chat if anyone in the audience has any suggestions, but for us that are doing research, it sounds like we are maybe building a consensus that looking at these sensitive optic nerve head parameters allows us to evaluate an actual functional change that might be potentially happening. Is there anything else? Do we have an agreement on what instrument to actually use when measuring it? I think we seem not to like the reliability of the diaton. Anybody can comment.
I think that really you have to use what you have, and not everybody has access to every single instrument for sure. And so, you know, in our clinic and just regular clinical care, we're using Goldman without a lens on the eye. And that's kind of what we're doing. And that's comparable to what the glaucoma specialists at Ohio State use as well. So at least we have a repeatable test. I agree that it's not ideal for an irregular cornea, but it's consistent and it's the gold standard. So that's what we use.
I agree. I think you need to use what you have access to and what's easier. For me, I just really like using the Tono pen. And so I've consistently used that. But I think more than which instrument, I think it's using the same instrument and looking at changes over time. So if I was doing Tono pen for 5 years, I'm not going to change to Goldman the 6th year. I think looking at consistency. And there's one question, I know we're out of time, but Karen DeLoss asked, do you think removal of a lens at night is enough to return eye to normal and protect against glaucoma? I think that's a really interesting question. I don't think we can give you a definitive answer, but I want to say yes, like probably, because it's letting the eye rest. Just like when you have a tight fitting lens and you see like a conjunctival imprint, or when you wear RGPs and you see corneal molding and you take it off, you know, I think the eye is resilient to some degree. And, you know, we still have perfusion. We still, you know, our IOP changes when you're doing yoga. Like, are yoga people doing downward dog going to have more risk for glaucoma? You know, our IOP changes all the time. So I think if you give it time to normalize without whatever factors that causing the change, it should kind of normalize, but I think we still need research to support that.
Yeah, and I think that really kind of brings it full circle back to, you know, kind of what Jason was bringing up in the beginning, that there's lots of compensatory mechanisms in a normal eye. You know, when I stand up, when I'm in downward dog, I'm one of those people, you know, the IOP is potentially going to be changing, but we have homeostatic mechanisms. So I think that we need to get more people like Dan and Nimesh Patel, who I work with here at UH, and some of our glaucoma experts, and work with them more and really figure out what's going on. But in the meantime, I think, you know, I always end these kinds of talks with, I have yet to pull a patient out of a scleral lens or not put them into a scleral lens because of IOP related concerns. So I think that's the sentiment. I've talked to all of you kind of personally with us, but, you know, as a researcher and constantly trying to find all the problems wrong with scleral lenses, I think hopefully we'll see more progression. And then I know we're a couple minutes over. I know Jan's going to want to say goodbye to everyone. Does anybody have any final comments before we let Jan close it out? All right, go ahead.
All right, well, thank you very much for your contributions. And next time, I hope we be in the same room. Bye for now.
And just a reminder of the new set of the next sessions. You'll get an email about these next Saturday and the Saturday after that. So Jan will be moderating next Saturday, and we hope to see you all there. Thanks, everyone. Have a great Sunday.
Bye-bye. Take care.